Okay, so good morning, everyone. I'm going to talk today about our experience at the University of Miami with laser interstitial thermal therapy for mesiotemporal lobe epilepsy. Um, we started doing these cases probably in around 2013, so it's been some time now. I think we've accumulated about 70 of these cases. Seems like a small amount over a long period of time, but again, back in 2013, this was a rarely used therapy. It's become more commonplace now. So going to talk about our experience and our own findings along the way, and whether or not this is an efficacious way to treat this particular problem. So hold on. So what is the scope of the problem? So epilepsy. So again, we all know what epilepsy is. I think sometimes we don't fully appreciate just how devastating this disease is for the individuals who suffer with it. But you can see here, as far as epidemiology is concerned, 80 of 100 in 100,000 people suffer with seizures. The lifetime incidence of a seizure is about 9%. A third of those are febrile seizures, which are, again, not that uncommon. Epilepsy itself is, again, 45 per 100,000 per year. The point prevalence is 0.5 to 1%. So when you think about that, you've got a population of about, at least in the United States, of about 300 million. So you can imagine that there is a huge number of people that suffer with this disease. Cumulative life incidence is 3%. And at least, in adults, mesiotemporal lobe epilepsy is one of the most common forms of focal epilepsy. So mesiotemporal lobe epilepsy is, really the area of focus here, especially in the adult population. As with, all diseases, really, you've got this very similar breakdown where you've got, responders to oral therapy. You've got about 30% of those patients with reduced seizures, 50% that seizures are eliminated, and you've got 20% with intractable problems. And we're going to focus obviously on that 20%, as we always do as neurosurgeons, right? Those that are intractable, oral medications not working, and the disease is really having a negative impact on their quality of life. So what happens if epilepsy is left untreated? So again, this is where I think, many times people don't appreciate the severity of the disease. When you look at somebody with epilepsy, obviously they don't look any different than really, anybody else. So it's hard sometimes to appreciate just how bad it is for them. But seizures are potentially life-threatening, as we all know. They're associated with, brain failure, heart and lung failure, trauma, accidents. You've got SUDEP, which is not a minor problem. Subtle seizures, even if, not severe seizures, can cause, further damage to the brain. And over time, this is like a cumulative problem. Long-term problems include fall in IQ, depression, suicide, social problems, significant quality of life issues. I mean, obviously, everybody here knows that, somebody suffering with epilepsy, can't drive, can't go to work many times, can't really function. So it's truly a devastating problem. I want to talk a little bit about the workup. We had these mock oral exams, and I was kind of surprised about about how little a lot of residents know about the actual workup for epilepsy. And it's probably the fault of the attendings in the department, maybe particularly mine as well. But the workup includes it's pretty standardized imaging, high resolution imaging, interictal PET imaging is a relatively standard image, neuropsychological evaluation, video EEG telemetry. I mean, those are the basic things that need to be done to try and prove whether or not where your seizures are coming from. There are other studies that can be added into that that are a little bit more difficult to obtain at times, but this is really the basics of what goes into a workup. Okay, and this data is accumulated over time, and then once you've got that data and you think that data is appropriate, it's presented in a multidisciplinary conference. That conference usually consists of neurologists, neuropsychologists, neurosurgeons. It's usually a pretty heated conversation, as the neurologists typically want more and more information, some of which can be invasive, and the neurosurgeon wants to, kind of minimize risk. It becomes sometimes a heated conversation, but at the end of the day, hopefully, come to a consensus. And that consensus really is whether or not the data you've accumulated is concordant. Best case scenario is that all of the information that you've acquired points to one location in temporal lobe and mesiotemporal structures. That's many times not the case. Most of the time, or many times, the data is not entirely concordant, and decisions need to be made as to whether or not further monitoring needs to be done. And if further monitoring, it's usually in an invasive form, whether it's stereoelectroencephalography with depth electrodes, or whether it's subdural grids and strips. All invasive, patients taking a risk. So this is kind of the standard workup. Typically, you see at the bottom of the screen here, you have this summary of what you've accumulated, the semiology of the seizure, which is very important. The video EEG information, both ictal and interictal data, MRI. Many times, if you can see a lesion, that's a good sign. That's usually implies that you have a higher rate of seizure freedom with surgery. Functional MRI to determine dominance of hemisphere dominance. MEG is one of these studies that's a little bit more difficult to get, but can be useful, showing interictal areas of activity in the brain. PET imaging, again, going back to the prior slide, this PET imaging here on the upper right hand corner is important. It can, if it's positive, it shows hypometabolism where the epileptogenic focus is. You can see in this coronal how you've got less, activity in the left temporal lobe here as opposed to the right, and that can indicate seizure focus. So what is in the temporal lobe? What is the anatomy in the temporal lobe? And again, this is very basic, but I think this really defines what, as a surgeon, you're dealing with when you're doing a temporal lobe procedure of any kind. You've got visual circuitry, you've got language on the dominant side, you've got memory in the mesiotemporal structures, and there's a lot of psychiatric implications when, removing tissue in the temporal lobe or ablating tissue in the temporal lobe. So these are the things that are at risk. This study here is a very important pivotal study. I think this is, considered level 1 evidence that anterior temporal lobectomy is effective. And, I think we should take a look at this anatomy here. Mesiotemporal lobe epilepsy implies that the focus is in this mesiotemporal structures here, typically the amygdalo-hippocampal complex. And one can see that with any temporal lobectomy, you are removing a substantial amount of tissue to just get to the area that is the problem. And, obviously we discussed what the temporal lobe is responsible for and what's at risk. A lot of neurocognitive issues when you resect a bulk of the temporal lobe to just get to these mesiotemporal structures. So again, we'd like to try and minimize things. This is a typical image of somebody who's undergone a temporal lobectomy. You can see just how much tissue needed to be removed, right, in this single cut just to get to the mesiotemporal structures, which are really the structures that you're trying to remove. This study in particular, looking at anterior temporal lobectomy versus just continued medical management, you had about 40 patients in each group, surgical group, medical group. MRI findings were pretty consistent in both the medical and surgical group. Patients were randomized even prior to their workup. These were all patients that had intractable epilepsy. And essentially what you see here at a year out is the significant difference in outcome between surgery and continued medication, right? It's very obvious. So percentage of patients without seizures impairing awareness, you had a 58% seizure freedom rate in the surgical group and only 8% in the medical group. And patients without any seizures whatsoever were 38% in the surgical group and 3% in the medical group. Some of the medical group patients crossed over and went into the surgical group. So at the end of the day, you had about, we'll get to that in a second. Let's just look at this. But essentially, you can see very clearly here, those with no seizures whatsoever, which is the blue, was substantially better in the surgical group, pretty much throughout the follow-up period. But again, what I was alluding to is that, let me go here. I was alluding to is that 36 patients in total underwent, after some crossed over into the surgical group, 36 patients in total underwent surgical resection with about a 64% seizure freedom rate at about a year. Let's just go back to these. So again, this just depicts the same thing. Quality of life improvement in the surgical group, statistically significantly better than the medical group. People returning to work, attending school. Again, you had a dip here at the time of surgery, but then obviously you see that the surgical group does better. So again, this is, really there's level 1 evidence. There's a couple of really pivotal, studies that show this. So anterior temporal lobectomy is definitely more effective than continued medical management in those suffering with intractable epilepsy. I just briefly put here the Engel classification, which, is somewhat important to know. There's many variations of this. This is kind of a simple form, but, what we're trying to always achieve is class 1. Class 2 is pretty good too, in my opinion, although they're left with some disabling seizures, but still a significant improvement. So it's an extremely effective procedure. And what's really critical to understand is that even though these studies have been published, since 2001 or earlier, it's an extremely underutilized therapy. It's really amazing, how many patients suffer with, intractable epilepsy of mesiotemporal lobe onset or temporal lobe onset and really don't undergo these life-changing procedures. So very underutilized. We can talk all day about why, but I mean, obviously, very few people are ready to sign up for craniotomies and temporal lobectomies, and there are risks to these surgeries. So, so it's not, that hard to believe that people aren't lining up for these procedures. So if you can do these things in a less invasive way, I think that is, important. Less invasive doesn't imply that the efficacy is necessarily the same. But, I think we should start to think about, reasons why people don't undergo these larger procedures and whether or not, doing these in a less invasive way opens up a new, way of utilizing surgery for more of these patients, right? So, and people have been doing this, for many reasons, trying to minimize, number one, the amount of tissue that's removed. So if you look at the anterior temporal lobectomy, we already discussed just how much tissue is being removed to try and get to these mesiotemporal structures. Selective amygdala hippocampectomy has been, done in the past. And again, there's controversy as to whether or not this approach is even as effective as a formal anterior temporal lobectomy. I would make the argument that it probably isn't, but I think it may be more effective in preservation of some of the cognitive issues that you see with an anterior temporal lobectomy, or some of the language issues on the dominant side that you encounter with, a full temporal lobectomy. So again, there are pros and cons of each of these approaches. I think, in my humble opinion, if you can minimize the amount of tissue being removed to get to these structures, I think one should infer that should produce, better neurocognitive outcomes. It's still disputable whether it does. I can hardly hear myself. I don't know whose that is, but anyway, so, as we move forward in time, you can see that, there's always been, this push to minimize the damage to the structures that don't necessarily need to be removed to get to these deep structures. And that brings us to, laser interstitial thermal therapy, which I think, at least in 2022 is probably the most selective in terms of minimizing the amount of temporal tissue, lateral temporal tissue or neocortical tissue that needs to be removed, right? So we're going to focus on that therapy today. So how does this work? This is a pretty standard, workstation for laser therapy. It's a 15-watt laser, 980 nanometer laser, and I'll show you how it's introduced into the brain. This is the laser applicator. So essentially this device is stereotactically implanted into the structures that you want to ablate. Lasers are not new to neurosurgery. They've been around for a long time in a handheld form, being used in operating rooms to incise and ablate tissue. The big advantage here, or the big advance here, is that this is done through very small holes in the skull, again, stereotactically. And, you know, what pushed this forward is the ability to use this in an MRI with real-time image feedback, the ability to obtain thermometry images via MRI so that you could really follow temperature changes in the brain. And then getting into the physics, the MRI physics, this proton resonance frequency of water, which this method really, you know, enhanced the way you can get thermometry with MRI. So it's these like last three things that have really pushed this therapy forward and made it, you know, mainstream. So wider clinical application, again, is improvements in temperature control with these lasers, which is done with use of circulating saline or you know, CO2, which then produces more uniform ablations, predictable ablations, less charring, less, you know, erratic temperature changes, which could, you know, make your ablation a little bit less consistent. This is just a simple way of looking at what this laser does. I mean, obviously we're taking light energy and it's being converted to thermal energy and heating up the tissue. And there is this sort of, what you see here is well defined as to how tissue responds to different temperatures. So below 43 degrees, you really don't produce any irreversible damage to the brain. Of course, you know, this is also time dependent. You want to really be in this sort of 45 degree to really 100 degree range to, you know, ablate tissue in a reasonable and consistent way. Once you start getting above 100 degrees in neural tissue, again, your ablations become erratic, there's charring, there's all kinds of problems. So it's really important to stay in this range here where you're irreversibly damaging the tissue in a relatively safe manner. And one can see why laser is advantageous, right? So if you look at other ways brain tissue has been ablated in the past, you can see with RF or cryo procedures, which have been used, the transition zone is quite kind of large. So the transition zone between, you know, irreversibly injured tissue to vital tissue is larger than what you get with the laser. So obviously that, you know, is a disadvantage and advantage for the laser. So, you know, tighter control of what tissue is being destroyed and what tissue isn't being destroyed. This is an example of, you know, experiments looking at the laser in tissue and how it responds and getting an idea of, you know, just how much of the tissue is being ablated. And on average, you get about, I would say about a 2 centimeter area around where your laser is that is, you know, supposedly irreversibly injured. And again, this shows what happens in tissue. If you've gone above 100 degrees, you get charring, which then impedes, you know, further temperature increase outside of that area, so that the ablation becomes, you know, erratic. Again, you also have problems if you do this with melting the fiber in the brain. So again, it's important to have tight temperature control, and that's what's important about this real-time MR thermometry. All tissue is not the same, and this is really critical, and we'll talk about this a little later. I mean, obviously, you have your laser properties, which are pretty constant, but tissue is different, right? So you look at tissue A, you get an ablation maybe about this size. Tissue B, you might get a larger ablation. So again, this is some of the difficulties you experience with ablating CNS tissue. And again, you know, not everybody's temporal lobe is the same. And that becomes really apparent if you've done this a number of times, that, you know, despite the efforts to improve the consistency on the laser end of these ablations, the unknown is the tissue that you're dealing with. And you know, ablations can be different in different patients. So that's important to remember. We're not going to go into this because I don't think I fully understand this. So key factors for lit: tissue penetration, tight temperature control, the sharp transition zone, and this real-time MR thermography is what's important to make this therapy work. Now, you know, when you start thinking about new procedures, it's important to think about, you know, as surgeons, right? Everybody, you know, go through residency. We see a lot of open surgical procedures. You see the anatomy under a scope or, you know, through your loops. you have to start thinking about things in a different way when you're doing therapy like this, right? You really need to start to understand the MRI anatomy more so than the open anatomy. And I think, that's as we move forward in time, I think that's going to become more critical, right, to training, right? Because, as procedures move towards minimally invasive, MRI driven, you really need to start to understand the MRI anatomy as much as you understand the open anatomy. And I think that's critical because, as you're going to see as we move forward in the talk, a lack of understanding of this on its own produces, complications that you might not necessarily, have to deal with open surgical procedures. So it's important to really start to understand the MRI anatomy, right? And so, when we first started doing this, obviously the MRI anatomy for the amygdala, head of the hippocampus, body of the hippocampus is pretty clear, but what is the anatomy around these structures on an MRI that you need to be aware of in order to prevent complications? And that might not be as obvious, right? I mean, we have really good, high resolution imaging these days, but again, there's a lot of things that are in the brain, right, that we can't see with these images, right? So it's really important to start to kind of understand this anatomy as well. So what are the important things around, around these types of stereotactic approaches? Obviously we already discussed what's in the temporal lobe. Obviously you want to, minimize damage to neocortical structures. You want to minimize damage to any of the visual circuitry. You really want to focus your lesion on the amygdalo-hippocampal complex. We should also understand that, laser, the physics of laser and the physics of spread of heat through this tissue, right, is important. CSF acts as a heat sink, right? So if you've got CSF, it's kind of protective. Heat does not cross those large liquid cavities. Peel planes may hinder the spread of heat as well. Vasculature, high flow blood vessels act as heat sinks. So, you start to understand that these are the things that might contribute to the inconsistency, right, of heat spread and tissue that's being ablated. And it's also to understand that you can use those things to your advantage, right? The ambient cistern protects you from having heat getting across into the brainstem. The hippocampus, for the most part, is surrounded by CSF. So, one would assume when you start doing these things that you've got good protection from the lateral portions of the temporal lobe by the CSF itself. But these are things that you have to start to consider when you're doing these procedures. This is a typical approach, again, coming from the occipital bone down through the axis of the amygdalo-hippocampal complex. And obviously the goal is to try and get this fiber into this complex for the longest, length of that complex as you can. So you have, as many options as you need to ablate tissue. This is a typical example of how this is done. You've got a bone anchor that's screwed in along the trajectory, screwed into the bone. This is how the laser is fired in sequential manner along the amygdalo-hippocampal complex, with the ultimate goal of ablating the entire complex. And again, you saw in this video using a stereotactic frame, which was, pretty much how we were doing these things early on. And again, there are some nuances that, need to be taken into consideration when using a stereotactic frame. Clearance of the occipital region as it relates to the frame, clearance of the bone anchor, so it's not hitting the frame. And since, we started using robots, we've not had to deal with that as much. So, the robot can be used as well to set the trajectory. This is a typical example in the operating room of, of planning out an approach. This has all been programmed into the robot, same way you would set a frame. And you can use this to deliver your laser fiber with a 3 millimeter craniostomy in the occipital region. And again, you see the robot arm is fixed along the trajectory. You drill your hole, you set your bone anchor back there along your trajectory, and then through that bone anchor, that's your conduit to deliver your laser fiber. This is a typical example. Once you've got your laser fiber in and you've moved your patient to the MRI suite, this is a typical example of your thermography. And what this allows you to do, as we saw when I showed you that, below 45 degrees, tissue is not damaged. So you can actually while you're in the MRI suite. You confirm the location of your fiber. If it's adequate, you put your laser through the fiber and you can fire the laser. And if you keep the laser at low wattage, you can fire at below that 45-degree cutoff so that you can see the change in temperature, so you know where your laser is going to be fired. And you can do that without damaging tissue. So you can confirm before you increase your laser wattage that you're in the location you want to be in. And this kind of shows it here at the bottom screen here. You can see where your temperature change was. You know that's where you want to be. So you go on to fire the laser at a higher wattage, and now you are at temperatures that will ablate the tissue. And this particular device uses what's called the Arrhenius equation to predict, where your ablation is. Anything within this yellow cavity is essentially assumed to be irreversibly damaged tissue. And you then, once you've done this ablation, you go into the MRI, you pull back your laser through the laser applicator to your new location. You do a sublethal dose again to confirm where you are, and then you just keep doing this in a sequential fashion until you have ablated what you want. Your final ablation will look something like this. When I originally started doing this, we were essentially ablating back to the tectal plate, which was what we, thought you would accomplish with an open, mesiotemporal lobectomy. So you would do this, then you would shoot some contrast, and you would see this cavity, and everything within this contrast enhanced area is presumed to be irreversibly damaged tissue. But we will see that that might not be the case. And this is what you're left with. Patient typically spends a night in the hospital and goes home the next morning. And again, people have done temporal lobectomies through very small incisions, but I think the key point here is there's no bony removal. It's a very small 3-millimeter hole in the occipital portion of the skull. Patients don't have a terrible amount of discomfort. So again, I think that's what makes this minimally invasive. Minimally invasive does not imply that there isn't equivalent risk necessarily, but minimally invasive implies that patients just seem to tolerate it better. So as we started doing more and more of these procedures, right, we started to, number one, notice some complications. Number two, we went on to think about, okay, well, how do we enhance this procedure? Are all ablations the same? Do they produce the same result? Is it about size? Size of the ablation, is a bigger ablation better? And, we looked at the seizure freedom rate. So we're going to talk a little bit about this. We also looked at, how accurate this intraoperative Arrhenius equation predictive model is. Is it really predictive of what tissue is truly ablated over the long term? So we'll talk a little bit about that as well. And again, we've already gone over this. You can just see again, this is your predicted ablation zone. And typically right after the procedure is done and you've shot your enhanced images, there's a pretty good correlation between this and what you see immediately with contrast enhancement. So went on to do about, early on, we did about, 18 of these procedures. They went extremely well. We were very happy with at least the short-term seizure freedom rates. And on the 19th, one of these cases, did it the same way, approached the amygdala hippocampal complex the same way, nothing out of the ordinary during the surgery. Patient wakes up and has a homonymous hemianopsia, right? And, obviously other institutions were doing this as well throughout that earlier time, and we're experiencing some visual deficits for sure. If you want to have a procedure that's less invasive but comparable to an anterior temporal lobectomy, you have to prove that it's as safe as an anterior temporal lobectomy. So the way to do that is obviously to look at it critically, right? So once you've developed one of these complications, I think the onus is on neurosurgeons with new procedures to go back and take a really, really close look and analysis and analyze for yourself what you did, why this was different, what happened here. And we did. We spent a great deal of time, effort, and energy on trying to figure out what happened to this particular patient. So this is how the patient woke up. And it's important to follow the patient out. So at about 5 months, you start to see some return of vision in this central sort of quadrant here. And so, again, we went on to analyze this. Now, when you're doing an open temporal lobectomy, right, and this, you have to realize all neurosurgeons, epilepsy neurosurgeons have been doing this for many years. When you transition to this sort of different approach, you tend to think, when you have the same complication, you tend to think about the anatomy as it exists when you're doing an anterior temporal lobectomy. You say to yourself, okay, well, it's obvious, the same way you get, a Homanis hemianopsia from an anterior temporal lobectomy, that's got to be what the problem is with this laser, right? It's got to be the same issue. But as we already discussed, your laser fiber is going to be about here in this tissue. And your optic radiations are in the roof of that temporal horn. So again, how does one explain how you're damaging these optic radiations up here, right, with a laser that's over here with all this CSF fluid protecting you, right? So this is what we really couldn't understand exactly what was happening. So we went on to use a system, a planning station that we had at the time, where you had an atlas, and this atlas was created by looking at 7 Tesla MRIs, and this came out of like Vanderbilt. And we had some questions. We looked at our cavity here, our ablation cavity, very critically, and when we looked at it right after surgery, we thought it was your normal standard ablation cavity. However, when we went back and looked at it more clearly, you could see this little blip of tissue here that was within this enhanced cavity, right? And again, if you didn't focus on this before the patient woke up, you wouldn't even notice this. But essentially, what you notice is this little blip. Now, the question becomes, is that blip important? So what we asked these Vanderbilt people to do, we asked them if they could turn on some of the anatomy in the thalamus for us. Particularly, our interest was the LGN. And the reason our interest was the LGN is because 5 months out, the way some of this patient's vision returned kind of led us to believe that this was an insult to the LGN. And certainly, when you turn on this structure, which is the LGN, it's right in this area of the thalamus that was ablated, right? So it became clear that we ablated this patient's LGN. Now, the question becomes why, and, what's the reason? I mean, the LGN really should be, or that area of the thalamus really should be protected by CSF in the choroidal fissure. And, it should be protected. It should be a heat sink between that and the laser fiber. So we did a really critical analysis of the 18 patients before. We wanted to see, well, okay, did we do something different in the planning? Is there a reason why this particular patient, developed this insult? And what you see here is a coronal image, okay? Your thalamus sits somewhere up about here, okay? And these are our approaches to the amygdalo-hippocampal complex. So this is the laser fiber and a coronal view. And what you see is this was the patient who suffered consequence. And certainly this patient had an approach that was on the higher side, but we had a couple of patients who had even a higher approach than this patient and never suffered a visual consequence. So again, it was clear to us that it wasn't entirely due to the level of approach to the amygdalo-hippocampal complex. So then we started to analyze volume of tissue ablated, volume of CSF. And what became apparent to us is, like everything else, not everybody's brain is the same. And, it's sitting in the choroidal fissure. You can see in this patient is a high volume of CSF, and this patient may be a mild volume of CSF. And then here, there's almost no CSF. So it's really this patient that you need to worry about, right? Because there's really nothing preventing heat spread from going superiorly in this patient into the thalamus, right? So it became clear to us that this was a combination of a higher approach in a patient, unfortunately, who had no CSF protection whatsoever. And again, we knew it was the LGN because if you look at the retinotopic arrangement of the LGN, right, it becomes clear that these central areas, right, are the furthest away from the heat source, right? So likely the areas that got irreversibly ablated were these areas here, which are, the peripheral areas, and the central areas, although dysfunctional from the heat early on, seemed to recover. So it was more evidence to the fact that that was the area that was involved. We also did some DTI at 5 months, and as you would expect, you've ablated the LGN, you've got less visual radiation fibers on the side where you ablated the LGN. So again, just more evidence of the fact that we ablated that nuclear structure. So what did we do to, moving forward? So, after a careful analysis, it became clear to us that this area is extremely important, right? And that, variability in CSF opens you up to this particular complication. And what's also critical is, early on when people were getting homonymous hemianopsias, they were blaming it on the fact that they were ablating too far back. But, I think it's clear that you'd really, if you're going to keep your ablation to the tectal plate, it's very hard to get these visual radiation fibers over here. So I don't think that was ever the problem. I think the problem really is the thalamus. And so what did we do? Early on, we were putting what are called low temperature markers on the brainstem. These are temperature markers you can set to turn off the laser if temperature goes above 45 degrees or so. So it's like a safety marker, and we were putting them on the brainstem, even though unlikely that the brainstem would get that amount of heat because of this ambient cistern. But we were never protecting in the sagittal plane the thalamus. So we started protecting the thalamus a lot better by putting these these markers there while we were ablating the body and the tail of the hippocampus. And I can tell you that, since we started making those changes, at least in further patients along the line up to 65, 70 patients, we've never had another, homonymous hemianopsia. So to me, at least, it's clear that this is the problem. We published a paper on this. Unfortunately, it hasn't really, the rest of the people doing this therapy have not really acknowledged the fact that that's the only problem. They still say that it's, other areas, other things going on. But I think if you protect this area, you're probably not going to have a homonymous hemianopsia unless you do something really stupid, like, extend your ablation, way, way too far back. There are other visual issues that occur with laser interstitial therapy, particularly double vision. It's a little bit harder to protect against this. It's typically, at least in my experience, from the trochlear nerve as it swings anteriorly along the tentorial edge. Heat spreads into this area, and you can heat the nerve. The good news is I've had a couple of these. They are all, at least all reversible. I think even in the literature, they're just about all reversible as time goes on. It's very hard to protect against. It's very hard to see this nerve. So, the only thing you can really do is change the way you deliver your laser energy in the body and the tail of the hippocampus, particularly the body. And, what you do is reduce the wattage and just allow the ablation to go for a longer period of time to achieve the same goal, so that you get, less of what I would call a jolt to the trochlear nerve. So going on to, whether or not all ablations are the same. So again, I thank Dr. Jermakowitz at the time for really, putting this together. And this really took some novel thinking on his part as to how to do this. We had, at the time, 23 patients, a mean follow-up of about, close to 2 years. 65% of the patients had mesiotemporal sclerosis. 78% of the patients were discharged on post-op day 1. But this is the key to, where he was thinking in a novel way, which was taking one of these planning stations, again, this Vanderbilt planning station, which allowed you to take sort of a brain with a 7 Tesla atlas on it. And they developed this technique where this brain would be deformable, and it would deform and fuse to any individual particular patient's brain. And then you can see the anatomy on your own patient's brain. But what he used this for was to take all of our patients' ablations. He would measure the ablation volumes, and he would normalize all that back to this single MRI. And what this allowed you to do was have all your patients now with their ablations, what tissue was ablated, all on a single sort of MRI, so that you could compare one ablation to the next and get a good understanding of what tissue was ablated, what areas were important to ablate, what areas were, not as important. And so what ends up happening here is after your analysis, you start to realize some really important things, right? So you start to realize that not all ablations are the same. It's not about the volume of ablation. A bigger ablation is not necessarily a better ablation. Getting more of the amygdala hippocampal complex isn't even necessarily, the important thing here, but it's about where your ablation is, right? So, it became clear that this leaving this sort of mesiotemporal tissue, right, which ends up being maybe the uncus, but leaving this tissue behind is not good, right? This is associated with less seizure freedom. You see in the ablations that come all the way to this, cistern, produced a higher level of seizure freedom. So, and that's depicted here. You can see that those with an angle 1 outcome had less tissue left behind. Here is 0 tissue left behind. And as you have more tissue left behind, you start to see, you start to fall into this group here. And again, we looked at and analyzed now in the medial to lateral aspect, where our laser fibers were. Did that have an impact on things? And it did. If your laser fiber was more lateral, right, you weren't going to get enough heat into those mesiotemporal structures. And again, you started to trend into this, angle 2 through 4 or less seizure freedom. And again, he was able to produce these maps by, normalizing all these images. And, it's hard to see with the colors used here, but essentially what it showed is the same thing, that the patients that had the best outcomes were the ones that had ablative cavities that were more medial and left none of this mesial hippocampal tissue in place. So again, at about little less than 2 years, we had a 65% seizure freedom rate, 73% in the group that had mesiotemporal sclerosis. And again, this is seen in papers with anterior temporal lobectomies as well. If you've got MTS or you've got a lesion, as I mentioned earlier, you're probably looking at a potentially higher seizure freedom rate if you've got a lesion in those structures. Looking at cognitive outcomes, so there was statistically significant verbal memory declines in the dominant hemisphere ablations. And again, this was not related to, seizure freedom or the volume of tissue you ablated or even the trajectory. So, again, there were some declines in memory. The likelihood of decline was much worse or was much more consistent on the dominant hemisphere rather than the non-dominant hemisphere. On the non-dominant side, we actually saw maybe a slight improvement in cognitive issues as opposed to the dominant side. And then this led to this multi-center study looking again to try, I think our paper led to this, which was, 15 institutions, 234 patients, again, looking at this same way of taking, all of your ablations, normalizing it onto a single MR and comparing, ablation cavities, what tissue was ablated. And it really confirms what I think, we found, which is that, again, across different institutions, different surgeons, you got the same type of sort of heat maps here. If you left mesiotemporal tissue behind, you were going to have lower seizure freedom rates, right? So if you left all this medial stuff behind, you'd have a smaller, this is what's called a positive predictive map. And you can see that this red, right, was extremely critical to getting a higher level of seizure freedom. So again, this analysis using similar techniques produced similar results. And this kind of shows you the same thing. The green, right, which is an estimate of what tissue was ablated, is more medial, right, to the red. The red were cavities that didn't produce the same seizure freedom rates. And also, this paper showed that, the rhinal cortices were also important to seizure freedom. So ablating, a little inferior as well, produced higher seizure freedom rates. So anterior medial inferior ablation cavity, rhinal cortices, in their 200. So in this analysis, at 1 year, 58% of patients achieved seizure freedom, and about 77%, if you included angle 1 and angle 2, were free of seizures, or not free of seizures, but fell into the angle 1 or 2 categories. So not bad, Again, in this particular study, they did not see a statistically significant difference in those who had mesiotemporal sclerosis or those that did not. It's unclear to me as to exactly why, but it wasn't statistically significant. And one of the other things that came out of this paper is, again, I said we were ablating back to this tectal plate typically. I think this paper kind of suggested that you don't need to be that far back, and actually you could be at this perimesencephalic sulcus was substantial, and that anything further back did not improve seizure freedom rates, but rather potentially increase complication rates with visual issues and things of that nature. So, again, I'm not saying that this is, perfect, but it is, some data to suggest that you don't need to be as far back. So now, again, I said we wanted to look at the predictive accuracy of this Arrhenius equation, right, which predicts at the time of surgery what tissue is irreversibly ablated. And I said that, at that time of surgery, when you do your post-contrast CT, there's a pretty nice fit. So, patient wakes up okay, and you feel pretty good about what you did. But what you end up finding out is that's not the case, right? And we started seeing this 6 months out. I would, we'd get repeat MRIs, and what you would see is here's your predictive map, which is the yellow at the time of surgery, and your ablation cavity kind of didn't really fit that as nicely at around 6 months, right? So we set out to try and figure out why. And, it was obvious to us that one of the reasons why is probably what we already talked about. Not all tissue is the same. There's different heat sinks in different locations. And so now we started thinking, well, is there a way to really predict this with MRI? Is there a way to predict, what temporal lobes might not, be ablatable or ablate as well? What, temporal lobes are going to ablate well? And we did a really, lengthy analysis of different things. That ends up being that, you really can't predict, but T2 signal intensity in the temporal lobe, there's some implication of T2 signal intensity. The higher the T2 signal intensity is, right, the more difficult it might be to ablate tissue. And again, I don't think that that's hard to understand. I mean, T2 signal is, water, and, we already discussed the fact that increased contents of water may hinder, thermal temperature changes or spread in the temporal lobe. So maybe that does play a role. It's hard to quantify this, so I don't know that that's going to help with anything. There were a couple of other statistically significant things that, kind of showed up. But again, these were things that I don't think you can really use from patient to patient to predict anything with certainty. But what you do know, and what's important to understand, is, as you would expect, the mesiotemporal structures, as we discussed, are the most important things to make sure you've ablated. And unfortunately, they're the hardest things to ablate, right? They're the things that as time goes by, it becomes clear that you might not have done as good a job as the predictive model suggests at the time of surgery. It's these areas that 6 months out have the most inconsistent ablations, right? So this may be a reason why, this therapy is not necessarily as consistent as you'd like it to be. Again, I don't know how you can control these things. You do your best to ablate this based on your predictive model at the time of surgery, but again, there is some inconsistency. And again, this just shows, looking again critically, what you see here is that, if you look at this axial, you've got in the blue, your lateral tissue that's being ablated and your medial tissue that's being ablated. And what you see here is, as you're delivering your therapy and as this Arrhenius equation is predicting what tissue is being destroyed, what you see is it takes a lot more time to ablate the mesiotemporal structures. In other words, this spreads more quickly on this lateral side than it does on the medial side. So clearly much harder to ablate this medial tissue than it is to ablate the lateral tissue. So it's not an even spread of energy, thermal energy, into these tissues. So we just recently published a paper on long-term seizure and psychiatric outcomes. So now this is looking, a lot of our early stuff was at 1 year, maybe 2 years. And, as you look at the anterior temporal lobectomy literature, it becomes clear that it's not, those time points aren't always predictive of real seizure freedom, right? Even with anterior temporal lobectomy, you get to about 5 years out, seizure freedom rate declines, right? So you really need to look at this and continue to follow this, further out. So at the time of publication, there were 48 patients. The mean follow-up period now is about 50 months. And, again, you see some things here that I think were, not, I didn't think we would see, but again, these are statistically significant pieces of data that came out of this. One is age at the time of LIT, and it's sort of counterintuitive that, it seemed like patients that were older had better outcomes. If you did LIT on patients who were greater than 50 years old, you had a higher likelihood of angle 1 outcome. Duration of seizure disorder, right? You would think that the shorter the duration, right, the better the outcome would be. But again, here, counterintuitively, it looked like the longer somebody was suffering with epilepsy, the better you did with LIT. MTS, again, like the anterior temporal lobectomy literature, it seems that, if you've got a lesion there, you were had a higher likelihood of seizure freedom. And then here, if you had suffered any focal bilateral tonic-clonic seizures prior to LIT, you had a less likely chance of being seizure-free, which I guess to some extent makes sense. The implications of that may be that there's, bilateral source potentially. And then this was another important finding, was that if you were psychiatrically asymptomatic in last 12 months of analysis, you had a much higher likelihood of being seizure free. So again, the implication of that is, that if you've potentially solved their psychiatric problems, you might have done an adequate ablation and produced a better likelihood of seizure freedom. So durability of this procedure. So, as we follow our patients along, we group them into different time points, right? And it's clear that this procedure is maybe not as durable as you want it to be. But, in the end, you still have about a 60% seizure freedom rate. And if you combine this with angle 1 and 2, about 75% of patients greater than 61 months out fell into this category. Again, you had about 83% of patients that were angle 1 or 2 at the time of publication of this study. And again, I think it's important to realize that this is not equivalent. By no means does this seem equivalent to anterior temporal lobectomy. All of these patients were on continued medication. So, in the anterior temporal lobectomy literature, there's a subset of patients who are seizure-free off of medication. I think it's clear, at least to me from this data, that I don't think LIT should be presented to a patient as a tool that produces seizure freedom in the absence of medication. Maybe you can reduce medication, but I think this is an adjunct to medication that may produce improvement in seizure frequency and seizure freedom. And again, just looking at the different things here, MTS. So again, those with MTS fared better. Those with a positive psychiatric those with a negative psychiatric history at follow-up fared better, which we already discussed. So again, I already discussed this. Essentially, this is what your outcomes are. I think it is important to understand that independent of these outcomes, what we did find is that in the last follow-up year, 83% of patients were seizure-free with medicine adjustments, so medication adjustments. So even those patients that kind of declined in terms of seizure freedom from the therapy itself, could be optimized with further medication to have about an 83% seizure freedom rate at last follow-up. So again, we already discussed this, and pre-surgical mood and/or anxiety disorders were identified in 30 patients and remitted after LIT in 19. So, LIT clearly can help with a lot of these mood, anxiety, and psychiatric issues that patients suffer with intractable epilepsy. Complications from this, so wound issues, about 3%, visual loss, 1.5%. When I say visual loss, this was not homonymous hemianopsias. That was one patient. But you do get your rare, diplopia. You do get your rare, quadrant anopsia, which you get from, you can get from an anterior temporal lobectomy, about a 6.2% hemorrhage rate, none of which were clinically, I would say clinically relevant, meaning, no clinical evidence, but only radiographic evidence. What I do think is interesting to me is that on every one of these cases that they woke up fine, post-op CT showed hemorrhage either along the tract or at some point, very hard to discern, right, it's either very hard to discern on your intraoperative MRI, or these are all related to removal of the fiber at the end of the case, because you just don't really, no matter how critically you go back and look at these images at the time of ablation, you really don't get a hint of any of these hemorrhages whatsoever. So again, not clear to me why, but that's just something, I've noticed. So conclusion, surgical intervention for MTLE is effective for sure, whether it's anterior temporal lobectomy, whether it's LIT, it's anterior temporal lobectomy is very underutilized. Again, we can talk for hours about why, but I think, LIT or these minimally invasive approaches hopefully will open up surgical therapy to more patients and help patients, whether or not it's completely as effective as an anterior temporal lobectomy. At least, more patients may be interested in this approach. And again, one advantage is if the laser fails, you can always go back and do a temporal lobectomy. It doesn't change the complexity of the temporal lobectomy. So selective procedures may be superior in preservation of neurocognitive function, although I'm not completely sold on that. Patients more likely to undergo LIT potentially. Older individuals, critically important. There are certainly older individuals who suffer with years of epilepsy who will not be candidates for open procedures, and LIT is definitely effective in helping those individuals. And I think it's important for at least me to take home messages. This is not necessarily a substitute for medication as much as it is an adjunct to medication to improve seizure outcome over time. And that's it. Thank you.
Dr. Jagged, on your complications for LIT of like 6%, these are basically asymptomatic and you just found them on CT scan postoperatively?
Yeah, correct. I mean, again, I'm sure there are many institutions that don't get these postoperative CTs. So, if you didn't get the CT, you wouldn't know that it ever happened. But yeah, all asymptomatic, at least asymptomatic from a focal neurologic issue.
Did you change your management based on the CT scan ever? I'm just curious because we always get MRIs post-op and I'm sure we miss hemorrhages, but that's like we were,
Well, I mean, and again, that's what I was showing where you see you're doing this in real time, right? So you have real time image feedback. And I can tell you that I've never appreciated on any one of those images at the time of the therapy, I never appreciated any bleeding anywhere. So my point is, I think without a CT, you probably aren't going to appreciate these little, clinically maybe irrelevant hemorrhages, but I guarantee you there are hemorrhages along the trajectory or the entry point or at various areas along your tract.
Yeah, I guess my question is, I guess, because if you're trying to do a prospective evaluation of the safety of laser for a variety of conditions which are basically a peripheral indications, and you get a CT postoperatively, then your complication rate was much higher than I guess if you just got an MRI, I guess.
Yeah. No, I agree with you. I think that may very well be true. If you got an MRI post LIT, I don't know if, I don't know what you would see on it. You may see nothing. That's
right.
a question.
Absolutely. No, it does.
Hey, John, Mike Ivan here. Great talk. This is kind of more of a theoretical question, but for epilepsy surgery, we always talk about disconnections, and if you disconnect the network, then that should treat the epilepsy. But now that you see that it's so critical to get like these very specific spots of the hippocampus, it leads me to believe that maybe we don't understand how to do disconnection surgery. There may be more connections there that we think, and that's why it's so critical to get these parts. Or do you think that by leaving the mesial part of the hippocampus, you're just not taking the whole track along that pathway.
No, I think it's the former. I think it's what you're saying. I mean, I think, and I think that becomes clear when you look at all of these other palliative, procedures that are being done, like NeuroPace, and this is not a this is a network problem. And I think, I would agree that, along those lines, I think it's the former. It's disconnecting these areas from this larger network that may produce the seizure freedom. I don't know if that answers the question, but that's what I think.
Yeah, I mean, it's just a question, if you're disconnecting the hippocampus more posteriorly but not getting the head, I guess the question is, is that head being connected to somewhere else?
Yes.
Yeah,
I think it
exactly.
is. I agree
Right.
with you. Yes, I think it is.
Yeah.
This is all about networks and connections, and if you're not isolating this completely, then I think you may have a higher likelihood of failing. Which is, which may, be the next thing to look at, right? I mean, there are ways to look at, how well you're disconnecting these areas from other areas.
Yeah, exactly my thought. When we might be able to do that soon, so we'll talk.
Yeah.
So today I thought I would talk about pediatric gunshot wounds. They've recently become the leading cause of death in children, which I think is pretty impressive that we have this many, that it is the leading cause of death. And as a result of that, I think it behooves all of us who take care of children to look at this problem and see what could be done about it. I have no disclosures, so a brief outline of the talk. I'm going to start off talking about the scope of the problem, some literature on pediatric cranial firearm injury. What do we know from some past studies that have been done? I'm then going to go through some of the papers that we have done and are working on with our own data, and then what can and is being done to try to tackle this problem. So firearm mortality, there are 45,222 firearm-related deaths in the United States for 2020. The firearm-related mortality rose 13.5% from 2019 to 2020. And obviously this increase corresponds with when the COVID pandemic began. But it's not clear that the factors leading to an increase will subsequently lead to a decrease down the line. This may be a more constant increase. Homicide rose 33.4%, while suicide rose 1.1%. And from 2019 to 2020, firearm deaths in 1 to 19-year-olds rose 29.5%. So that was more than twice as high as in the general population. This graphic came out in the New England Journal of Medicine this year, and I think is a pretty impressive graphic that makes us all take pause. So what you'll see here is that in 2020, firearm injuries overtook motor vehicle accidents as the leading cause of death in children 1 to 19 years of age. We talk a lot about tumors, accidents, other causes of death in children, but previously, motor vehicle accidents were the biggest cause of death. You can see here in the 2000s, there was a major decrease in the fatality of motor vehicle crashes. And that's due to a combination of things. Traffic safety laws, better car seats, better seatbelt and car seat use, sort of a multifactorial approach decreased our motor vehicle deaths in kids, as well as access to care and care on the clinical side. In contrast, firearm injury has really had this sharp uptick and now has crossed over as the leading cause of death. The annual mortality rate for pediatric gunshot wounds was 4.19 deaths per 100,000 in 2017, and before that had been 3.57 per 100,000 in 2004 to 2010. If we looked at today, it would likely be significantly higher. And cerebral gunshot injuries make up about 40% of these firearm-related deaths, but they do have a much higher mortality than other pediatric firearm injuries. So there are two good papers that I thought were worth us taking a minute to discuss that have a significant number of pediatric cranial gunshot patients. So the first was published by WashU in 2012 on their experience. They looked at patients that were aged 0 to 18 years of age. They are a metropolitan level 1 trauma center. And the time period over which they collected their patients was from 2002 to 2011, and they had 48 patients. So a decent length of time ago, but also a larger series of patients. So they identified 8 statistically significant factors, which were predictive of a favorable outcome. And I think a lot of these will not come too much as a surprise to people. If you had single hemispheric involvement, absence of a transventricular trajectory, less than 3 lobes involved, greater than or equal to 1 reactive pupil on arrival, a systolic blood pressure greater than 100 on arrival, absence of deep nuclei and or third ventricular involvement, or an initial ICP less than 30 when monitored, and absence of midline shift, you likely were going to do better. Of these, 5 of them, when they did additional analysis, were strongly predictive of a favorable outcome. And they defined a favorable outcome as a Glasgow outcome scale of 4 or 5. So the 5 that seemed to matter most were absence of a transventricular trajectory, less than 3 lobes involved, greater than or equal to 1 reactive pupil on arrival, absence of deep nuclei and or third ventricular involvement, and initial ICP less than 30 millimeters mercury when monitored. They came out with a scale to try to predict likelihood of survival. You get 3 points for their primary predictive criteria, 2 points for their secondary predictive criteria, and 1 point for their tertiary predictive criteria. I'm going to go through this in a bit more detail in some subsequent slides when we talk about the validation of this with a subsequent paper. And they used a cutoff of 5 of being predictive. So I think 2 of the more interesting take-home points from their series were that the pediatric population demonstrates a more favorable outcome than adults, meaning that children who look very poor on initial arrival may be more likely to survive than adults. I don't think this surprises anyone. We know that children have more plasticity than adults, and we can see some amazing recoveries in our pediatric patients from injuries that we would not expect an adult to survive. So they argued that you should potentially be more aggressive in children than in adults. And they also notably had 3 patients with a GCS score of 3 on initial arrival who did survive. So the next paper I wanted to go through was one out of Memphis from Boop and Klimo. So looking at their experience, they had similarly patients aged 0 to 18 years of age. Theirs was from the 2 level 1 trauma centers that they see patients at from 1996 to 2013. They had 71 children included in their study, which included 57 male patients and 14 female patients. And the mean age in their study was 14 years, but ranged from 19 months to 18 years. Mortality was 47.9%. And of the survivors, 81% had a favorable outcome, which they defined as a Glasgow outcome score of greater than or equal to 4. Their predictors of mortality were fairly similar to the prior series I showed you. Bilateral fixed pupils, deep nuclear injury, transventricular projectile trajectory, bihemispheric injury, injury to greater than or equal to 3 lobes, systolic blood pressure less than 100 millimeters mercury, anemia, Glasgow Coma Scale less than or equal to 5, and also they included a blood-based deficit of less than -5. So I don't think these are surprising. It makes sense to us that if your condition when you come in is poor, you've got fixed and dilated pupils, low GCS score, or if the injury is crossing critical midline structures or involving more of the brain, you're likely to have worse survival. Similarly, if you have a low hematocrit or low blood pressure, you've probably already lost a lot of blood, suggesting potential vascular injury as well. So with the Memphis paper, they looked to see whether using their data, they could validate the St. Louis grading scale. And going through this in a little bit more detail, because I thought the figure from this paper was better. The St. Louis grading scale, the things that got you 3 points from the primary predictive criteria were bilateral fixed pupils on arrival, involvement of the deep nuclei and or third ventricle, and ICP greater than 30 if there was an ICP monitor. The secondary points, which would give you 2 points each, were mixed supra or infratentorial involvement, at least 3 lobes involved, although if it was the cerebellum, then only a single lobe would get you these points, and transventricular injury. And then the tertiary predictive criteria, which led to 1 point each, were bihemispheric injury, blood pressure less than 100 millimeters mercury on arrival, and midline shift. So you could get a total possible points of 18, and 5 was used as the cutoff in terms of assessing between ones that were likely to survive and not. So they found that the positive predictive value of the St. Louis scale in predicting death for a score greater than or equal to 5 was 78% from Memphis. But interestingly, the negative predictive value, if the score was less than or equal to 4, was 93.3%. So this was actually a little bit better at predicting who was likely to survive than who was likely to die. What have we seen in our patients? So the first thing I'm going to go through is our survival patients for cranial gunshot wounds to the head from RIDER. Victor took the lead on looking at this with us. And we just published this paper in Child's Nervous System recently. So we queried the RIDER database for patients less than or equal to 18 years of age from 2011 to 2021 who had a gunshot wound to the head and who survived with at least 1 documented follow-up. So we had 19 surviving patients of 36 overall gunshot patients that we had identified. So this was a 53% survival rate. Our average age was 15.3 years. 95% of the patients were male and 79% of our patients were Black. So this is not hitting all of our patient populations equally. There definitely are certain patients who are, or certain populations who are more at risk of suffering cranial gunshot wounds. And I'm going to talk about that a little bit later in the talk. 63% of the patients had isolated head injuries. The average GCS on arrival for those that survived was at 11.9, and 84% had reactive pupils on arrival. So this does tell you that we had a sizable number that had non-reactive pupils on arrival, but did go on to survive. In terms of the hospital care, these patients all received antibiotics and antiepileptics. 37% required intubation, 21% received hypertonic solution, 11% underwent an XLAP for additional bullet wounds. Bedside debridement was pursued in 32%, and EBD was placed in 21%, and 79% had surgical intervention. We looked at complications, and by this we meant medical complications or medical issues they had, not specifically complications that we would present at M&M. So 68% had complications. Sympathetic hypertension was seen in 5 patients, or 26%. A decent number ended up with infection, so 4 or 21% had pneumonia, 2 or 11% went on to develop meningitis, and 1 or 5% had sepsis. Other complications seen in about 2 patients, or 11% of cases, included seizures, facial droop, fevers without infectious source, diabetes insipidus, CSF leak, and pseudoaneurysms. In terms of how they were doing at discharge, on average, they were discharged on post-injury day 22. So these patients stayed in the hospital for a long time for many of them, particularly the ones who are sicker. Their average GCS on discharge was 14. Patients discharged to non-home settings were more likely to have had an intraparenchymal bullet trajectory and intraparenchymal hemorrhage on their initial study. But I thought it was worth going through one case that we included in that paper that I think shows us that we're not always great at predicting which of these patients will or will not survive. So this was a 9-year-old male who presented to RIDER. He did have a GCS of 8 on arrival, and he had a bullet trajectory that came in the left forehead, crossed over, and then came out in the right parietal region, unfortunately going through the MCA branches and causing injury to the MCA branches. And you can see how the skull was blown out here. He came in when Dr. Ragib was on, and given the concern for bihemispheric injury, and there was strong concern about whether or not he would survive. My understanding is Dr. Ragib did not feel that it would be safe to do a hemicraniectomy given the MCA branch injury. He was concerned that a hemispherectomy would lead to substantial bleeding if that bone was taken off. So he opted to manage him medically with an EVD placed, but was very concerned that this was a non-survivable injury. Subsequently, Dr. Wang took over his care, and later on in the care, I took over his care. His ICP was very difficult to control. Despite maximum medical management, he remained with very elevated ICPs for a number of days, making concern for whether or not he would survive even worse. But ultimately, his ICPs did come down, and during the course of his stay, his exam improved to following commands. He subsequently had his EVD weaned, and then on day 23, the M4 pseudoaneurysm, which you can see here, was embolized. He did have some additional small pseudoaneurysms off of the ACA branches that Dr. Stark embolized this aneurysm, and discussion, he did not feel those would be amenable to embolization. Those were ones that needed to be treated open, the ACA branch ones. And he started to have a question of CSF leak around that same time with some droplets of fluid that we noted on the forehead incision. And so as a result of that, he went to the OR on day 26 for repair of his skull fractures, dural repair, and Dr. Stark also joined to deal with the pseudoaneurysms from the ACA branches. By the time of his discharge on day 42, he was ambulating. And when I last saw him in clinic, he was oriented ×3, full strength and normal gait. That was about a month or two out from his discharge. He subsequently, the patient was actually originally from farther north in Florida. So we transferred his care as an outpatient to the UF group. But I've spoken with the mom on the phone, and he's went back to school, is doing okay in school, but has some concentration and memory issues. As you can imagine, he's not perfect after this injury. But overall, if you just met him, you wouldn't necessarily know he had been through all of this. So I think it is important for us to remember that we're not always great at predicting. There's some where it's very obvious they're not going to survive, but there are some that we think have a low chance that may actually make it through. So currently, one of our medical students is working with me to look at all of our cranial gunshot patients, both the survivors and the non-survivors, looking over our databases. We have about 2 to 10 pediatric patients per year. So it does vary a bit from year to year, the number of patients, but unfortunately we do regularly have pediatric patients with cranial gunshot wounds. I'm also working with our general surgery colleagues to look at some of the national data. And so this is a project that I started with Chad Thorson, one of our pediatric surgery attendings, and the 2 surgery residents working on this are Rebecca Saberi and Teddy Huerta. And so we've looked at the nationwide readmission database. For those of you who aren't familiar with this, it's one of the Healthcare Utilization Project databases. It's released annually. It comprises 15 million admissions across 22 states, representing 51% of all US hospitalizations. And the neat thing about this database is that you can track patients across hospitalizations at different hospitals. So if they go into one hospital, they're discharged and they have a complication, usually you would miss them if you were just looking at one hospital. But with this, we're able to track them across those hospital visits. It's multi-state data from about 17 million discharges annually, and it's weighted to estimate roughly 36 million discharges. It includes de-identified patient demographics, diagnoses, procedure codes, length of stay, and characteristics of treating hospital for each patient encounter. There are a couple limitations. It can't track readmissions across state lines, although HCUP estimates that less than 5% of readmissions occur across state lines. It also does not include race. We can look at income of the household or insurance status of the household, but we cannot look at race using these databases. So we queried the NRD database from 2010 to 2014 to identify patients who were less than 18 years of age, who were admitted for a pediatric cranial firearm injury and had a diagnosis of traumatic brain injury. We found 1,365 pediatric patients with cranial gunshot wounds from 2010 to 2014. This accounted for 11% of all pediatric firearm injury. 83% of the patients were male, 81% were age 13, 50% had Medicaid insurance, and 79% of the patients came from the lowest 50% household incomes. Most of the patients presented to large hospitals, 81%, and teaching hospitals, 89%. And the most common comorbidities were mental illness, with 20% of the patients carrying this diagnosis code, and drug abuse with 10% carrying these codes. And we wanted to really look at what was the mechanism of injury, because if you're going to look at how do you prevent firearm injury, the prevention is going to be different depending on the mechanism of injury, and the outcomes may be different depending on the mechanism of injury. So assault accounted for 51% of the injuries, self-inflicted for 25%, and unintentional 24%. Female patients had a higher rate of unintentional injuries. Male patients, not surprisingly, had a higher rate of assault injuries. Assault was most frequent in our 13 to 18-year-olds, 88%, versus self-inflicted, that was 84% in this age range, and unintentional was 60% in this age range. Unintentional was most common in 7 to 12-year-olds and less than 6-year-olds, with 20%. Being 20% in that age group being these causes. So that was the most common cause in these ages. Self-inflicted injury was more common than assault or unintentional injury in those with the diagnosis code of mental illness, 44% versus 9% versus 20%, and drug abuse, 13% versus 11 versus 3. It also resulted in substantially higher mortality, 63% versus 44% versus 32%. Assault compared to self-inflicted and unintentional was more likely to occur in low-income households, 61% versus 31% versus 42%, and to survive to discharge, 44% versus 14 versus 39%. So if you look at this table here, and I'll point out, the star is because the way this database works, if you have too few patients that it could lead to a HIPAA violation, then it requires you to censor the data and not include it. So if we look here for assault, you can see there's a huge increase in the likelihood of that with the lowest median income quartile. Self-inflicted really crosses all demographics with a slight increase towards lower income, but this does affect large numbers of the population sort of across the board, but unintentional, once again, has a higher tendency in the lower income. Unintentional compared to assault and self-inflicted injuries was more likely to occur in those less than 13 years of age, 40% versus 12 versus 16, and more often resulted in facial fractures and subarachnoid hemorrhage. Those with assault were more frequently, as I mentioned, from the lowest median household income quartile, 61%, and more frequently utilized public insurance, 65% versus 50% in all patients with pediatric cranial firearm injuries. The mortality was 43%, and it's notable that this is markedly different than the 6% mortality that's seen in all pediatric firearm injuries. So not surprisingly, these are much more lethal. 35% were discharged home, 14% were discharged to a skilled nursing facility. For those that survived, there was an 11% 30-day readmission and a 21% overall readmission rate, and 7% required unplanned operation on readmission. So you can see this has a very large healthcare cost in terms of the number of days stayed in the hospital, as well as readmissions and procedures. Self-inflicted had the highest mortality rate, 63%, and coma rate, 76%, and assault had the highest unplanned readmission rate versus self-inflicted or unintentional, 57% versus 0 versus 7. The self-inflicted patients also had higher rates of dysphagia, brain death, and brain edema. And the assault and unintentional had higher rates of hydrocephalus, hemiplegia, convulsions, epilepsy, and CSF leak. I questioned whether some of these increased rates were due to higher survival in the assault and unintentional than self-inflicted. But when we try to correct out for that, it appears that there still seems to be an increase in these risks. So obviously, as neurosurgeons, we also need to think about spine injuries in addition to cranial injuries. So Victor also took the lead on this rider project, and this was looking at our pediatric spinal injury patients with gunshot wounds. So we queried the rider database for patients less than or equal to 18 years of age from 2011 to 2021 with a gunshot wound to the spine and at least 6 months of follow-up. This is in press currently in JNS Peds. And we found 13 patients. 92% of the patients were male. 85% of the patients were African American. 77% were from zip codes with a median income below the county average. So very similar in terms, we can't pull out race from the nationwide readmission database, but in terms of the fact that we're skewing towards patients with a lower median income, we're definitely seeing this in our own patient population. The minimum GCS was 14. Most of these patients had spine injuries only. And Asia A classification was really across the board. So we had 3 patients who presented as Asia A, which accounted for 23% of our patients, 2 patients with Asia B, 15% of our patients, 1 patient would be categorized as Asia C, so 8% of our series, 2 patients with Asia D, 15% of our series, and 5 cases with Asia E, which would be 38% of our series. We saw facet injury in 10 patients, or 77%, pedicle injury in 8 patients, or 61%, and intracanal injury in 9 patients, or 69%. The median hospital stay for the patients was 12 days, but it ranged from 1 to 88 days. There was no mortality. There was a 15% readmission rate, and we only had 1 patient who had an improvement from their initial Asia score. That was a patient who had a bullet that was compressing the spinal cord. That was Dr. Niazi's patient. We've discussed it at conference before, that after relieving, that it was a rare case where surgical intervention was beneficial in relieving the compression on the cord, and that patient has seen substantial improvement over time. So this is obviously a major problem, that this is now the leading cause of death in children. So how do we decrease firearm injury and death? We can come at that through a multi-prong approach. We can try to impact care in the field and transit to the hospital. We can try to impact hospital care. And then we can try to reduce injuries in the first place through policy change or community programs. Unfortunately, I think a lot of these injuries, the die is cast when that injury occurs. So though we can try to do everything through care in the field, rapid transit to the hospital, rapid OR, many of these patients, there's not much we can do after the injury has happened. And so we really do need to look at policy change and community programs to try to reduce the fact of these injuries happening in the first place. I think this is probably a little bit different than the systemic gunshot injuries. There's been a lot of work on trying to the sort of stop the bleed campaign and reducing blood loss from injuries. And that's really not going to make as much of a difference with these cranial injuries. So I was privileged recently to attend the second medical summit on firearm prevention. This was an invited hybrid meeting. Some people attended in person in Chicago and others of us attended virtually, that happened earlier this month. It was co-hosted by the American College of Surgeons, the American College of Physicians, the American College of Emergency Physicians, and the American Academy of Pediatrics and Council of Medical Specialty Societies. There were 47 organizations that participated. And you can see here, it's a broad number of organizations across multiple medical specialties. So ophtho, orthopedic surgeons, family physicians, emergency medicine, trauma, OB-GYN, nephrology, thoracic surgery. And I attended as part of our pediatric section. After Uvalde and Buffalo, there was a significant discussion amongst those of us on the pediatric section, executive board, as well as members of ASPN, about what our organization should be doing to combat this problem, particularly with the release that this was now the leading cause of death of children. So we did put together a combined statement from the pediatric section and ASPN that's available online, as did many other medical organizations after this. And we were invited to attend this summit. I don't think there was any adult neurosurgery representation at this summit, but there were a number of members of us from our pediatric section, executive group, and ASPN who attended. And these were some other groups. There were some policy groups, nursing groups involved as well. So the idea of the summit was that it built on a prior summit that they had hosted back in 2019. That summit had the following recommendations and goals. They wanted to address firearm violence as a public health crisis, research the public health crisis using a disease model, engage firearm owners and communities at risk as stakeholders to develop firearm injury programs, empower the medical community across all healthcare settings to act in the best interests of their patients in a variety of palpable ways, and commit professional stakeholder organizations to ensure that these statements lead to constructive actions for improving the health and well-being of our nation. I thought it was interesting that of the potential policy recommendations that they thought it would make sense to push for, the sort of three that they settled on back in 2019 as being likely to both affect change and be more likely to be accepted by both wide swaths of the medical organizations themselves and the public, were background checks for all sales and transfers, requiring firearm owners to provide safe and controlled firearm storage and hold those responsible who do not. And then the third one was interesting. It was formal reassessment of firearm designations. So they made the point that while outright bans of assault weapons can be fairly political and controversial, and there are going to be people who are very upset about that idea, it may be more palatable and more expeditious to reclassify those weapons as a specific category that requires additional training and licensing to obtain rather than an outright ban. And then obviously we could debate that for quite some time of what the best approach is to that, but I thought that was interesting that they thought that was a more expeditious path forward. So the objectives of the second summit were sort of a broad sense to identify opportunities for the medical community to reach a consensus-based nonpartisan approach to firearm injury prevention, to discuss the key components of a public health approach and define interventions this group will support, and to develop consensus on actionable items for firearm injury prevention using the public health framework. And on a more specific level, there were sort of two main approaches. One, to use a consensus-based nonpartisan approach to selecting recommendations for executive action and/or legislation at the federal, state, and municipal levels that would decrease firearm-related injuries. And two, identify elements of the most effective programs that can be implemented by physician practices, clinics, hospitals, and health systems in partnership with their communities to effectively lower the risk of violence for marginalized communities that are disproportionately impacted by violence. So this was a two-day summit. There were talks from leaders in the field in terms of both policy change and community action type programs, and as well as those who are experts in terms of the trauma literature and outcomes. And in addition to that, there were small breakout group sessions to discuss what could be done. So my sort of take-home points from listening to the summit were: one, we need to better understand the causes and risk factors of different types of gun violence because the approach will be different depending on the type. We need to work with communities to reduce risk of violence and get buy-in from local communities. One of the examples they gave was, it's not going to be very reasonable to tell someone that they need to safely store their gun with the ammunition separate from the gun if they live in fear that someone is going to break into their house and want their gun close by so that they can protect themselves. So you need to figure out where people are coming from and then what strategies might work to improve safety based on where they're coming from. They also talked about minimizing the use of divisive language and how depending and actually went through examples of what might be better or worse language to use in discussions. Gun violence definitely disproportionately affects certain communities. Two of the stats that I found pretty impressive were that you're 8 times more likely to die of gun violence or firearm injury in Mississippi than you are in Hawaii, and you're 20 times more likely to die as an adolescent Black versus white male. So there was much discussion that policy changes are needed at the state level in addition to the national level, and even potentially at local levels as well, and that we need data to understand which of these policy changes will actually be effective and what's needed. So we had a lot of discussion during it on state laws, and I realized that I didn't really have a good understanding of what our state laws were, and realized that many of you may not either. So I thought I would take a minute to go through that as well. So Florida does not require a permit or license to buy a firearm. There's no registration required. You do have to be 21 or older unless you're law enforcement, a corrections officer, or in military service. This law changed after Parkland. It was not a 21-year age restriction prior to Parkland, and a lot of lobbying after Parkland was one of the things that changed this age restriction. A license is required to carry a concealed weapon, and there are some restrictions in the laws on gun ownership for people of specific categories. Those who have convicted of felony, dishonorably discharged, some mental illness, convicted of domestic violence. So there are some restrictions there. There is no limit on the number of firearms an individual can own or the number that an individual can buy at one time. Background checks are required, and they require a 3-day waiting period, though counties can require 5 days. There's exceptions to this, so I'm going to go over this on the next slide. And you're not allowed to carry visibly, so you can't walk around with a weapon visibly shown, although there are exceptions to this. If you're on your way to go hunting, you are allowed to do that. So between the purchase and delivery of any firearm sold by a licensed firearm dealer, there is this mandatory waiting period. It's either 3 days, excluding weekends and holidays, or the time it takes to complete the required criminal background check, whichever occurs later. Now, it does not apply to holders of concealed weapons permits. It doesn't apply to the trade-in of another firearm, and it doesn't apply to the purchase of a rifle or shotgun by someone who has completed a 16-hour hunter safety course and possesses a hunter safety certification card, or to purchases by law enforcement, correctional officers, or service members. We do have child access prevention laws in Florida, and these state that any person who stores or leaves a loaded firearm on premises under his or her control, who knows or reasonably should know that a person under age 16 might gain access to the firearm without permission of their parent, must keep the firearm in a securely locked box or container, keep the firearm in a location which a reasonable person would believe to be secure, or secure the firearm with a trigger lock. So this does not apply when the adult is carrying the firearm or has it in close proximity. And notably, it only makes the person who fails to store the firearm criminally liable if a minor gains access to the firearm without permission of their parent and exhibits it in a public place or in a rude, careless, angry, or threatening manner. So there's no penalty for this, basically, unless something bad happens. Notably, there are no laws that require them to be stored in a specific way, and it does not require a locking device to accompany the sale of a firearm. I thought I would end with this graphic from the Journal of the American College of Surgeons from back in 2019 that I think outlines things quite nicely. Too often, we're trapped in thinking about this as a problem where nothing can be done because people are on one of these two sides, either the firearm and violence narrative that firearms are generally harmful, they're generally unnecessary in civil life, they decrease personal liberty because of increased risk or harm, They're an emblem of violence, and gun control translates to violence control. So get rid of guns, they're bad. Or the firearm and freedom narrative. Firearms are generally beneficial. They're necessary for personal protection and safety. They're protected. They're a constitutional right. They're an emblem of freedom. And gun control translates to freedom control. And I think, you know, many of us as individuals have strong beliefs on where we fall in terms of guns, but they make the point that we're more likely to make progress if we instead focus on what they term a common American narrative, which is inclusive of these two conflicting narratives and focuses on the idea that it's a liberty protected by the US Constitution, but violence is a major cause of preventable death and suffering. And we need to significantly reduce death and disability by working together, understanding and addressing the underlying causes of violence, and making firearm ownership as safe as possible. In terms of acknowledgements, I talked to you about the two projects that Victor has spearheaded. Becky and Teddy are two of the general surgery residents who've been working with me on the nationwide readmission database project, and have also contributed to our rider projects as well. And then these are some of the additional residents and students who have worked on these projects. And these are the faculty that have also contributed to these projects. Thank you. With that, I'll take any questions. And I should have mentioned, Rider also does have outreach programs to the community as well.